I'm Lisa Suennen. We're delighted to be here with all of you today for the UCSF Health Hub Digital Health Awards pre-discussion and chat. And we have two groups with us today, but your group is the new Telehealth Innovation Group. And we're going to spend a little time first asking you to do a brief intro. And by brief, I mean like the elevator one sentence description of your company, your name and your company. And then we're going to go into a discussion. It'll be kind of a bit of a free for all, but if nobody's being engaged, then I will call on you just like it's fifth grade. It'll be super fun. But the whole idea is to have an informal and casual chat, but just to talk about issues and make it interesting because this stuff will be seen by others. And you want to show off your best thinking. So my name again is Lisa Suennen. I lead Venture Valkyrie. I'm also now president of Canary Digital. And delighted to be here today. I'm going to hand this off to Vivek Rakora.
Thanks so much, Lisa. Vivek Vishwanath, Chief Growth Officer and co-founder here at Rakora, where we are an enterprise platform for providers and payers for maintenance and recovery care. So starting in heart health, we provide the staffing, technology, and platform needed to take control of a virtual footprint.
Thank you. Sebastian?
Thank you, Lisa. I'm Sebastian Sager. I'm the CEO of Emoca Health. We help every patient take every dose of their medication using technology and also a virtual care team.
Well, I was hoping you were providing every patient with coffee for free, but that's okay.
Well, you never know. You never know.
Dwight?
Hi, I'm Dwight Chu, CEO of ZephyrX. We do home diagnostic testing for respiratory conditions, and we do it with a twist. We do it with a live video call because that pulmonary function test is a difficult thing to do by yourself.
Mm-hmm. Great. Valdrin?
Hi, my name is Valdrin Luca. I'm Chief of Growth at HelloCare, Collaborate. We are an end-to-end platform for telehealth and virtual healthcare delivery with artificial intelligence, which we do virtual patient observation, e-sitting, RPM, and we also integrate artificial intelligence to do fault prevention and fault detection.
Super, thank you. All right, Drew?
Thank you. My name is Drew Bussos. I'm the Chief Strategy Officer of Science 37, and Science 37 executes tech-enabled clinical trials that are faster, that are more inclusive and patient-centric.
Super, thank you. Amanda?
Hi, everybody. I'm Amanda Johnson. I'm a primary care doctor and assistant vice president of care models at New York City Health and Hospitals. We're the largest public healthcare delivery system in the country. And we partnered with DocGo for the Street Health Outreach and Wellness Program, which brings street medicine and other mobile services to New Yorkers experiencing various forms of homelessness. DocGo is a provider of mobile health services and transportation services on a robust digital platform.
Super. All right, Neil, thanks for coming.
Hey, everybody. Some technical snafus. Pleasure to meet you all. My name is Neil Batlivala. I'm the co-founder and CEO of Pair Team, where we connect underserved communities to high quality care by working with safety net clinics and providing wraparound care teams and technology.
Terrific. Thank you. Let's see. Who have we missed? Elena.
Hi, everyone. My name is Elena Mosteza. I'm the CEO of Bolt Health. We're a specialty virtual care provider for digestive conditions. We treat gastrointestinal illness with an integrated multidisciplinary approach that combines evidence-based behavioral therapies, nutritional therapies, as well as more conventional medication, bringing together long-term longitudinal care that's more effective and cost-efficient for patients experiencing GI disease. Thank you.
Noel.
Hey everyone, my name is Noel Kershakani. I'm the Chief Growth Officer here at Andor Health. Andor Health has been around now for over 4 years and a Microsoft M12 portfolio company. We've been focused on bringing an AI-powered virtual health and collaboration platform, both in the at-home and acute settings, leveraging certain AI models in order to drive workflow orchestrations to deliver care in a virtual environment.
Great. And Richard?
Hi there, I'm Richard Hanbury, CEO of Sonna Health. We're in audio-visual neuromodulation, which is essentially anxiety relief on demand. So think about us as a future replacement for many of the current drugs, a tool in the toolkit in every area of pain and mental health where anxiety is a component.
Okay. And Ryan, I think you're the last one.
Hi, everyone. Ryan Delarami. I'm the founder and CEO of TeleView. We provide telepresence solutions using augmented reality and artificial intelligence delivered by smart glasses. So think of it as virtual care 4.0.
Great. Okay, thank you, everyone. So I guess in light of what you all do, I think the first question I'd like to ask about is the complexity that's been introduced for patients by specialty telehealth. I mean, it used to be that you'd go to your health system or your primary care physician and there was a small network of doctors and they were kind of all somewhat sort of kind of linked anyway. And, you know, you knew where to call more or less, unless you had some unusual specialty condition. Now it seems like we've moved to a world where we're splitting patients across many companies in theory, you know, for the specialty of this or that. Each of you has many different specialties. I think Science 37 is a little bit of a different animal in some ways. But is this better or worse or the same for patients? How are we doing in light of this sort of decentralization of care delivery, given the specialty telehealth model that's come to fruition over the last few years? Whoever wants to jump in first. All right, Dwight, you win.
So yes, I agree with you that there's a lot of complexity that's been introduced to the patient. One thing that we've found is that in our space for respiratory care, there are actually over 5 million patients in the United States that are over 2 hours away from a specialized pulmonologist. And being to have that same diagnostic capability at home, especially if you're on oxygen, let's say you're a COPD patient, you have an oxygen, traveling those 2 hours to get to the specialist, it's probably more complicated than being able to do it at home. So we find that there are certainly advantages in spite of the complexities that sometimes are introduced.
Okay. Ryan, did you want to say something?
Yeah, in line with what Dwight said. So from our perspective, if you think of some of the, first of all, our platform is a peer-to-peer platform. So it's mostly between healthcare professionals. And secondly, if you think of some of the remote and rural patients, to Dwight's point, they would take several hours and several thousands of dollars in some cases to travel to centers to receive care. With our platform and with this kind of technology collective with the other groups, you're hoping to bring that care closer to home. So patients are a little bit more sort of content with going to the doctor as opposed to spending several, if you think of Northern Canada, which is where we first went, like some of these patients don't even go to receive care because of the cost. So that's what we're hoping to bridge with the technology.
Okay, Drew, want to go? By the way, you can use your little raise hand feature as well. It might make your lives easier. Drew, go ahead.
Thanks a lot. I don't think it's about complexity. I think it's really patient optionality. And I'm really pleasantly surprised of all the finalists that are here. Not surprised that they're here, but it's just the fact that technology, if you design it in a way that it fits or it's focused on patient care, it's really going to deliver some benefits. And those benefits are going to outweigh really somebody may say the difficulty in trying to use it. I'm sure everybody here, but I could just speak here for Science 37, we've designed our workflow to be very patient-centric. So whether you're a nurse, a patient, an investigator, which is another fancy word for a physician, if you design the system in a way that it really helps and accelerates what you're trying to do, I think that's at the end what people are going to benefit. So I think that really, really impressed with everybody. And I think that what I'm hearing from Dwight and Ryan was, hey, you're solving a need that is really being unmet. And that's really, there's a bit of a cost behind it, but if you design it right, it's going to benefit the patient in the end.
So I'm going to go to Noel first and then Elena.
Thank you. Yeah, I think there's a couple of fundamental realities that the healthcare industry is dealing with right now, which is creating a very interesting sort of perfect storm. The first is, fundamentally, I think, and historically, patients still prefer to have healthcare delivered locally as much as possible. However, because of the fact that the industry is dealing with specialty shortages, they're dealing with staff shortages, an inability for these patients to get access to care, what's happening is that the market, in particular the health system space, is trying to find the right partnerships to actually sort of augment their own service lines and present those access points directly to their own patient populations. The complexity that we're finding is that there is still a lack of orchestration, both at a data level as well as at a pure workflow and operational level, in order to make that experience very consistent for the patient. Mm-hmm. What we're finding, take for example, we're hearing a lot about behavioral health in the ED, right? 12% of patients that are admitted to the ED today are considered to have a behavioral health concern, right? How do I pump in a behavioral health specialist when the only one that I have that's currently on shift takes 4 hours to get to that particular patient, thereby clogging my ED? There has to be a way to fundamentally leverage specialty networks in conjunction with that particular health system delivery mechanism in order to properly align the services with that particular patient population.
Okay. Elena?
Thank you. So we're a specialty care provider for gastrointestinal disease. This is one of the largest specialty areas. And I do believe in specialized care where you have the expertise that can treat patients more than, would be in a primary care generalist setting. What we're trying to do, we're actually doing multidisciplinary care. So we bring in different type of experts, but with the GI angle. So a behavioral health therapist that can treat someone with gut issues, a nutritionist that also has that expertise for GI conditions. And then we have the doctor, the nurse that brings in, diagnostic medication. So it is more integrated, but around this condition area that requires expertise to treat it very well. Then it would be done, in a more generalist setting. We haven't yet figured out how to integrate with other diseases, but we are, as much as possible, looking at the person as a whole person, system, behavioral, physical, biological, and even social determinants of health. And I would say technology really allows us to do this integrated care much more easily and empower the patient to be a player in their health, because they get patient education, and they can track, they can get behavioral advice, lifestyle support, as opposed to, depending on that one interaction with a provider at times.
Neil.
Yeah, I kind of want to tackle this from a couple of different angles. One is, from a patient experience, I think that having these point solutions, so to speak, non-bundled solutions, provides more effectiveness of care, right? A virtual clinic that treats substance use is going to do a whole lot better than it, and like a broad solution there. And it also pushes the industry towards interoperability. No one can just stay their lane. They have to have a component of care coordination to provide a good patient experience, which I think is a net good thing, and pushes also a trend towards more data sharing and interoperability, which again is a good thing. And I think from a broader market perspective and buyers, no one wants to buy, you look at these plans, no one wants to buy a bunch of small point solutions. They're looking for a new opportunity of these aggregators coming out. And this is somewhat where we play. We are a broad, we provide advanced primary care and social care coordination, but we partner up. We partner up with a lot of these condition-specific virtual clinics because they're just going to do a better job than us, but that's fine. We want them to do a better job. And so I think it's pushing the industry in the right way, but also super natural to have an unbundling and then rebundling as new tech comes in play.
Ryan?
Yes, I also wanted to add I guess this is on us as technology companies. So when we design technology to bring into healthcare, we have to be mindful of the existing workflows. Oftentimes, some of these workflows are 10, 20, 30, 40 years old. And we are trying to introduce a new technology into an old and broken workflow. We not only make, but we actually make it worse. So oftentimes you bring in technology and people say, hey, it doesn't work. That's because you haven't redesigned the workflow to integrate with the technology. And I think that's an important factor for all of us as we're trying to bring technology forward for our healthcare providers.
Yeah, interesting. I'm going to go back for a second to Neil, and I'm going to play devil's advocate with you a little bit. You made a lot of assertions. Point solutions are better care. This pushes things to be more coordinated and this data to be more integrated. I would argue it's the opposite in some respects, not always, but why is your care or somebody's care from a point solution better than the care delivered at, a really good clinical organization?
I guess I come from the safety net primary care world where all these clinics are underwater. And so I think about it on a core focus and core capabilities perspective, right? I don't mean to make any of these statements with like hard, nothing's black and white, yes or no on all this, but at least when you are a primary care physician and you have 1,000,001 things to do, and the administrative, like all the things that we know that drive burnout, having a partner who's really dedicated to the thing that's top of mind for the patient, the condition that, the care that the patient needs right now, having a partner that's their core capability, that's their core competency, really can lead to better care. Now, that said, I think you always need to evaluate it on a case-by-case basis and all of that. And, there's no single protocol that rules them all, so to speak. But in a overworked clinical setting, I think having some of those point solutions available as extended capacity for a patient can be a really positive thing.
Okay. Vivek?
Yeah, Neil, I'll add on to that. So what we've seen in our experience at Recora is that you don't need to necessarily think of it as a binary between a point solution and a best-in-class model of care. Our model involves us becoming an extension of the existing virtual components of a service line. So take cardiac rehab, for example, which is one of our first programs. As a virtual cardiac rehab provider, we partner with the existing facilities at a health system. The patient's medical director is receiving all patients on a panel, and we're servicing those who may have never come into the clinic in the first place, but could benefit from a life-saving intervention. And so at the end of the day, by bringing the staffing and the technology to the table, we're able to extend the reach of the health system, but the same clinical protocols that have made them a recognizable brand still play out for our existing protocols as well. And so I don't necessarily see that being a binary. It really just depends on the structure of the partnership. What we found to work really well is being that virtual first service line that it basically becomes the extension of an existing clinic.
Great. Amanda?
Yeah, so I think the diversity of the panel is amazing, and it just goes to show that the safety net patient demographic that we're talking about is also diverse in and of its own right. I think many of our patients would bristle at the thought of enlarging their care team even more than it has been already, just because of the degree of fragmentation that they experience. So I think the fact that we're able to deliver consistent care teams with a platform that allows for continuity across encounter, across the city, is really what builds that trust that gives us an advantage with our patients in terms of being able to improve their care. I think also what you consider bread and butter primary care is going to vary based on what you think the top needs are of your patients. So we would not consider substance use treatment or being able to refer someone for social needs or mental health services necessarily a specialty. I think 80% of that work can be accomplished through those relationships that you're building as these core care teams, and it's great to be able to customize the platform to build up the capacity to handle an ever expanding number of substance use concerns in that community primary care setting that is the park, that is the subway, that is the street corner. And then once those relationships are built, if people do have a need that can't be met in that particular care relationship, yes, then we can back into and leverage the virtual care platform that we have either at health and hospitals or through .go. But one thing that we hear from our patients loud and clear is they don't want to deal with more people. They don't want to be their own care coordinator for all of the various inputs and plans that are coming their way.
Yep. Let's see, Richard.
Yeah, I think I'm going to sort of build on the last three things that are said. As a point solution, we are providing a much better way of addressing some of the issues, but it only works if we are actually plugged into the system in the right way. So we are a point solution that is adding to care, but only if we are actually in the system in the right way.
So in other words, several of you believe that there's no way to displace tradition. There's only ways to augment it. True. All right. Who believes that? Raise your hand. Interesting. Okay. The minority. Dwight.
Yeah, so I'll just echo on someone mentioned that there's also a explosion of solutions that are presented to providers. So providers have to deal with this myriad of different point solutions out there. And I would say that there are probably two areas that are going to help down the road for that. One is we're just seeing consolidation within the industry. So there are fewer people, they're aggregating solutions, just with that consolidation. I think the other thing is that to the degree that technology providers build their systems from the ground up to be modular and to be integratable with other partners, I think that's going to help the industry as well.
Great. Noel?
Yeah, I mean, the only thing I was going to say, just leaning on what you were mentioning earlier, the question you had, I think that having a broader ecosystem of specialized network providers, network services, things of that is a good thing. Being able to create those types of access points to the population, that's something that we've never really had before in broad spectrum. The challenge that I think that we're struggling with right now, particularly as an industry, is how do we fundamentally bring that back to a whole person-centered type of model, whereby, you know, that particular patient can be monitored, managed appropriately, you know, either by the local entity or in line or in conjunction with those particular service arms. We've already learned this lesson the hard way, right? We basically took years ago, we could barely even get data to be exchanged between a health system and a primary care provider. And now we're layering on a whole new ecosystem of players, and we still haven't solved that problem of just being able to share data and share process between the two. So we've exponentially created a much bigger problem in the market. I think to the point that was made earlier, I don't remember who said it, if those relationships are structured in such a way that the operational workflows are more efficient and the technology underpinnings are very, very well orchestrated, we can create much more disciplined and much more disciplined operational workflows that support a consistent experience to the patient. I think that is what a lot of the health organizations right now are trying to think through. What is that ecosystem and how do I connect all of them together to create that experience for a patient?
Sebastian.
Yeah, Lisa, you had just said you had compared to the traditional model. So that sounds like a benchmark of like, what were we doing 15, 20 years ago? If you look back like 50
years ago.
Or yes, exactly. If you look back 50 or 60 years ago, though, I'm not saying that that's a place we want to be, but if you had a heart attack, you'd be in the hospital for like 4 or 5 weeks, and every part of your care that was, you know, you would rest, your medication regimens would be stabilized. Specialists would be brought in at the right time, and it might take a little longer. So since then, we've dropped length of stay, for example, for that heart attack to like 24 hours. So now what we're trying to do, and you hear this point solutions, you're recreating the time that you need with that patient to deliver care. You're recreating that. It's not going to change how much time it takes for somebody to fully get back on their feet. I mean, the drugs are amazing. The procedures are much better. They're less impactful. That's true. But we're pushing the patient out of that. And not only that, not only are we pushing them out of the hospital setting, but in clinic, there's no time. There's no time. Providers are stressed. Nurses are stressed. They're entering data here, left and right. So what's left is companies such as, you know, all of us to deliver pieces of that care, because we're not hospitals. We don't have the full spectrum of services in pieces when the patient needs it. It's generally to their benefit if the coordination is appropriate. Like if you take Dwight's services, patients need, the respiratory status does need to be tested at times. Can they drive 2 hours? No. So,
Neil, do you want to comment?
Just wanted to add, I think there's this comparison of these point solutions against tradition. And I guess part of the way I see it is we're trying to change tradition. We're trying to improve upon the best practices. I look at each of these condition specific clinics as kind of petri dishes. Petri dishes where we're better using data, we're better able to assess what best practices should look like. And please want other, the larger health systems to take on those best practices. And so over time, we're going to see a natural consolidation as we figure out what works and what doesn't. But that kind of evolution of what is tradition and what should be that best practice.
Well, I'd agree with you, except for I'm a realist. Yeah. And I don't think that's how it's been working, right? I mean, I think, one of the biggest challenges in this whole thing is how do they even find you? How do the providers know to refer to you? Even if it was coordinated through, New York Health Hospitals or some other health system, the process from getting the contract done at, the CMO or, whoever level up there to it becoming a simple way to refer people into your system is nowhere near reality yet. And then, oh, by the way, let's not forget the insurance part of this, which is they may or may not be willing to cover the extended service that you provide. You'd have to do it under the contract of that provider organization. It's a mixed bag to do that, all of those issues. And I haven't heard any of you really talk about that issue yet, which is how do they actually get to you, through these partnerships, and how does it actually get covered in any other way, if there is another way than them being, you riding under the contracts of the systems that exist, good or not as they may be, and I'll stipulate, and a lot of them aren't so great, but I think it's as big a problem as being rural. Is even if you're in New York City, how do they know, the patient, or how even the physicians that are in the extended program of these facilities or health systems to find you? Noel, are you looking to comment? You have your hand up. Or is that
I'll give you some experiences from what we've seen from a lot of our customers. Now, you guys know Andor Health is not a services partner. We're an infrastructure player. So we work with health systems and provide them with a virtual health orchestration platform around these types of things. Case in point, by need, a lot of our health systems are selecting these types of point solution partners to actually work with because they struggle with just maintaining the right staff to manage the volume and demand that's coming in. But here's a good example. One of our health systems that we work with, one of the biggest challenges they had, big children's facility, pediatric institution, they had their EDs just compressed significantly during the pandemic and even now. But what they're finding is that if it's I'm just using the behavioral health example as a good one. They had one, maybe two behavioral health specialists that were even available to support any type of, for example, a suicidal event or anything along those lines. It would literally take them about 4 weeks just to get a behavioral health specialist to meet with somebody who entered the ED. So what they did is they ended up partnering with a third party that was accretive to their own business model, because fundamentally, if they could triage a patient in advance, navigate them to that line of service, and still have that particular patient fundamentally managed back at the health system, that was a better way to, I think Sebastian mentioned it, get faster access to care, but also keep that managed and orchestrated appropriately with the health system that's currently local. So I think that if we're really going to make the point solution model work, which I think, again, is a good thing, and I think is the right way to present very new and innovative ways of delivering care and better services, I still think that there is a need to manage those orchestrations and those services in line with the local facilities.
Yeah. Richard?
Yeah, thank you. I would say it depends on how big and desperate the problem is that the solutions are solving compared to current examples. So for us, getting physicians to cooperate in fibromyalgia, neuropathic pain, and some of the mental health areas is really easy because they're desperate and they're already looking. So we'll look at the early adopters because they're already out there looking. That's how we start to change the standard of care. I don't think these things are possible where you're not solving a big enough problem. I think if the problem's big enough, people are already looking for the solutions, and that's what makes it easier for them to find us.
Fair point. Dwight?
So, we provide remote respiratory care in the time of COVID. So the demand was pretty high early on, and we were able to get emergency contracts with, many of the top institutions throughout the United States. But in reality, it took us probably 18 to 24 months to get full master service agreements with, 40 plus hospital systems. So I would say, we certainly haven't figured out how to get the attention and let them know that we have services available I would say this, the second thing you asked about reimbursement. We've been lucky in that we actually have CPT codes specific to our home respiratory testing. So we're able to get the physicians paid for the work that they do with our system. But that's not always true with obviously all different point solutions out there.
Vivek?
I think all of us like solving hard problems. It's why we're here. And it's not going to be easy to fix every piece of this experience right out of the gate. But the thing that breaks first is a patient's experience and their continuity of care. And so for us at Recora, our biggest challenge and our biggest opportunity has been in finding the ways to better integrate with our provider partners, building the EHR integrations or the workflows that help us deliver just as much of a virtual experience as the in-person cardiac rehab facilities can. And when we do that, the end result is a streamlined experience for the patient, an ability for us to make sure that patients who are never being identified before are getting identified for life-saving programs. Referrals are getting placed in an automated fashion for services instead of relying on a cardiologist who may have 100 things to do that day with a patient. And at the end of the day, we can handle some of the background functions from kit logistics in the home to virtual care enablement that a traditional healthcare player didn't necessarily build their entire infrastructure around. And so I like to joke that we've learned more about what it takes to get an older adult onto a Zoom call 2 to 3 times a week than we have about specialty care in the last couple of years. But it is, in fact, what's allowed us to be a really good partner to the providers out there, chasing after a really big problem. Heart disease kills 1 in 3 of us, and yet less than 20% of people are getting the rehab that they need. So it's about finding those aligned places where providers see value in you taking over some of the work, being willing to take on the tough challenge of the integrations, and then being able to keep that patient experience continuous regardless of how they're receiving care.
Drew?
For us, as you mentioned, Lisa, we're in a different category. There's about 3% of physicians that participate in clinical trials, and only about 8% of the population participates in clinical trials. So it's been, and why they do it, there's a myriad of reasons, right? But we do know that we need to continue to foster research and development and do it in a way where you get participants of all different ethnicities to participate. For example, latest stats that I had seen, only 14% of studies had people that were underrepresented, right? So therefore, you need to increase that number. And there's a huge issue with awareness and as well with access to healthcare, but most importantly with trust. And that is one of those things that you need to try to overcome through the different technologies. I think everybody cited it. I'm not going to repeat it in depth again, but I live in north of Philadelphia and west of Manhattan. So for me to get to either Philadelphia or Manhattan is going to be an hour and a half. I don't have 3 hours a day to drive to a medical site in order for me to do something that I could do at home. Now, I need imaging as part of my study. I'm not just going to get a flatbed in my driveway and do it, right? But there are alternatives, and there are things that you could do with partnerships in order to be able to provide that care that patients need in order to continue and succeed.
Sebastian.
Yeah, the health plans, especially in the Medicaid side of things, are bearing increasing risk on the patient experience, and I think the CAP scores are going to be in Medicare weighted like 5x now. So the health from our perspective, we work with some great health systems, but we have so much more impact when we help people take their medication every day via the health plan, because we're not dependent on all of these topics like the integration with this or that, or whether the provider has the time to recommend it to the patient. We can go direct to the patient. We'll involve the provider if we need to and if we can. And at the same time, I think, though, that the health plan is demanding that the patient experience be very, very positive. And that pressure is going to come down onto the health systems as well, because there is so much reimbursement at play, let's say from the star rating translating into the amount of the capitated payment that the health plan is going to get. So bypassing the health system to a certain extent is what I think a lot of valuable point solutions can do. And to point solutions, sometimes you find that the point solution is the solution. So with medication, if you don't take your medication properly, you're in the hospital, period. sometimes that is the solution. I'm sure a lot of people feel the same way about the specialty that they've developed.
Neil?
Yeah, just on the notion of like, how do we get in front? How do we get exposure to the services that we're providing? I think we're all building out, ultimately the ROIs with the health plans. Like, why should we? We're fighting tooth and nail to get those first couple of contracts, to get those, first set of pilots, to then demonstrate it, which then de-risks it for future plans, and then has them pushing you down and saying, is this a benefits program that I want to make available to my patients? For us, for example, we're helping to look at, the role of community health workers and social care coordination with clinical work to ultimately reduce total cost of care. And, I think ROI will ultimately speak for itself here, and what makes it kind of mainstream.
Somebody finally brought up evidence. I love that. Because we haven't heard that yet in this fairly lengthy call. And I think, one of the things I've seen as an investor in the space is very little attention to real ROI, economic ROI, or fundamentally better patient experience, including the integration experience. And so I wonder, who might like to talk about that a little bit. And Drew, I know you have your hand up. I don't know if it's for this topic, but.
Yeah, I had it before, but it's quite okay because we just got finished creating an ROI model. So one of the challenges that we're having is our main customers are sponsors, right? Pharma companies that are looking to conduct trials. And they've been doing things for the same way the last 60 to 90 years. So we're coming to disrupt that. So many times the pandemic, they didn't have an option. That really helped us and fueled our growth. Now that we're out in a different way, right? There's vaccines and we know a little bit more about the disease. They're going back to, do I really want to do this or not, right? And so anyway, we've created a series of case studies and as well a lot of public data that's available, whether it's Tufts or anything like that. And we're arming these sponsors. So like, hey, depending on what you want to do, what is clear is that no two trials are alike, right? Because the protocols are unique and they're very different. But we do know, hey, here the average site, that means a hospital that turn it up, is about 31.4 weeks, according to a recent study. And it costs about anywhere 50 to 150,000. So we are available to do it. And in many cases, we've also had ROIs or case studies to say, what are the things that we could do? One of the tangible pieces, we're a publicly traded company. So in our whole filings with NASDAQ and SEC and so forth, we were able to prove that we could do 21 times faster patient recruitment, retain them. In the study, about up to 28% more. And then diversity, we're able to recruit 3 times. So it's about 42%. So we'd love to be able to share that, but it is individual for each one. But we do have that data.
Good. Thank you, Drew. All right, we're coming to the end here. So if you want to say like a 1-sentence thing, Ryan, or whoever else just had their hand up, like you get 1 sentence. What is it?
On the ROI piece, I just wanted to quickly comment that there are really 2 types of ROI. One is the marketing type ROI, which you have to come up with something really quick to show people, hey, this is working. But the true ROI is if you do a proper study that is at scale to be able to show, let's say if you're showing that you're improving patient outcomes, it's not going to happen with 10 patients in one hospital. You need much larger population of study. So I just want to distinguish between published ROI as a marketing tool versus true ROI where it's meaningful to the organization.
Agreed. No, one or 2 sentences. That's it.
Yeah, all I was going to say was just kind of hitting on what Ryan was saying before, which is truthfully, the ROI in and of itself is dependent upon who you're working with at that moment in time. So I mean, like for our health systems that we work with, for them, it's about how do I reduce my left without being scenes in the ED? How do I, drive more patient volume, but the right way, and right sizing care directly to my organization so I don't lose that demand down the road. So we have a lot of case studies built around those types of models. It all depends on who you're working with and supporting in the system itself.
All right, Dwight, 1 sentence.
So we're seeing, a lot of burnout in the pulmonology space, especially with respiratory therapists. And what we're finding with our system, they can do a remote pulmonary function test far more quickly than in clinic, so they can be 2 or 3 times more productive, or use that much less staff given the burnout.
Okay, great. Well, thank you, everybody. I really appreciate your participation in this discussion. It was nice and lively, super cool. We're going to switch over now to the patient cost savings topic. What I'd like to do as we launch into this patient cost savings discussion, which is probably the one I've spent more on in my career than any other topic in healthcare. I'd like to first start with asking each of you to give a 1-sentence introduction to yourself and your company. 1 sentence, like 30 seconds, no longer. I'm just going to call you out. So Vera, if you could start, please.
Yeah, sure. I'm Veera Ananta, founder and CEO of Constant Therapy Health. We provide digital speech and cognitive therapy to patients at home after an event such as stroke, traumatic brain injury, dementia diagnosis, or other types of neurological disorders. And we do this through our platform that delivers AI-based therapy to these patients at home, as well as tools for clinicians to really monitor the care for patients in the clinic.
Great, thank you. Sean?
Hi, I'm Sean Tibbetts, the VP of Strategy for Neuro Rehab VR. Our flagship product is the XR therapy system. It's used by clinicians, caregivers, and patients to provide physical, occupational, and mental health therapies, while also supporting the aging communities, decreasing fall risk, all done in immersive 3D virtual reality environments. The XR therapy system increases therapist efficiency, reduces the amount of time needed to reach care plan goals, and most of all, improves patient outcomes. We're also the first company in the world to create a board-certified CEU course teaching clinicians how to incorporate VR into their care plans.
Okay, thank you. Michael?
Yeah, hey, I'm Mike Havoc. I'm an orthopedic surgeon and founder of HealthMe Technology. We're basically a marketplace platform that really allows patients to shop for healthcare like they shop for every other product, which is digitally. They can't do this now because most doctors don't know how to retail their services. And we really accomplish this task by giving doctors a turnkey solution to bundle price and actually retail transparently priced healthcare bundles directly on their websites. And so basically, we like to say we're like Shopify for healthcare. And by doing this, we give patients access to reasonably priced care, and we give doctors the ability to grow revenue through basically a patient base most of them are missing.
Okay, thank you. Graf?
Hi there, I'm a nephrologist by training. I'm also the Chief Medical Officer and co-founder for Maya MD. Maya MD is an AI engagement platform essentially to deliver value-based care. We go into organizations such as nephrology space, which has been hit hard by value-based care for the past couple of years. Reducing total cost of care is what our goal is. We provide multiple touch points for the patients using digital therapeutics, including RPM, CCMs, medication monitoring, as well as compliance.
We've almost got the whole bingo board covered now with all the acronyms. Okay. Mark?
Hey, I'm Mark Miller, Chief Commercial Officer with Wildflower Health, and we deploy a combination of technology and services to both payers and providers, really bridging payers and providers to help accelerate the successful transition to value-based care in women's health, helping patients engage and actually know what they're supposed to do, helping providers have the information and connect them with their patients so they can do what they want to do, and then making sure that we're aligning the payment model between the payers and the providers so that as providers continue to invest in improving outcomes, that they're positioned to gain the value of that as well.
Thank you. Todd?
I am president and co-founder of Clarify Health Solutions. We exist to empower individuals to live 3 to 5 better years by creating a marketplace whereby life sciences, providers, and payers can partner to create the incentive programs that are truly driven to deliver better outcomes for individuals. And so we've been in business for 7 years, enabling those types of payment models, contracts, and incentive programs. Honestly, very similar to the way in which Mark is doing in women's health and Amy's doing it at Turquoise. So excited for this conversation.
Terrific. Shirley?
Hi, I'm Sully Dvorsky, co-founder and CEO of Tailorman, and we work with a provider and pharmacy network to find patients that have high out-of-pocket expenses, especially around their medication costs. And then we help identify them early in their medical journey, find third-party financial resources that can alleviate their financial need, and then enroll into those programs. By that, reducing their financial hardship and financial toxicity, and helping our provider and pharmacy customers to be financially whole.
Thank you. Amy?
Hi, I'm Amy. I am the VP of Growth at Turquoise Health. We were founded in 2020 on the heels of the price transparency legislation. Our mission is to reduce the cost complexity of healthcare. And really, we've been focused on this price transparency data that's been made available starting with hospitals in January of 2021 and now payers just over this summer in July. July 2022.
That's been going real smoothly, huh?
Real fun.
Rich?
Hi, Rich Press from Sunprey Health. I'm the VP of Life Sciences Partnerships. And we at Sunprey, we uniquely align the pharma and health plans to reduce the out-of-pocket costs for prescriptions so that the patients can afford them, and then use dynamic discounts delivered over SMS text messages to patients to encourage them to take their medicines on time and to stay adherent on therapy.
Cool, thanks. Tatiana?
Perfect. Hi, everyone. My name is Dr. Tatiana Fofanova. I'm the co-founder and CEO here at Coda. Coda Health is a patient-driven platform for shared decision-making and decision capture that navigates advanced care planning conversations at scale. Basically, you can think of it like TurboTax for some of these difficult conversations in healthcare, but with a much higher engagement rate of nearly 5 times the national average. Because at the end of the day, a patient with a plan saves systems over $10,000 per patient, helps them hit their performance metrics, and fundamentally, it means we get to deliver the care that people actually want at scale for less.
Great, thank you. Ashish?
Thanks, Lisa. My name is Ashish. I'm the growth lead here at Samaritan. Samaritan is a support platform that provides unconditional financial and social support, as well as incentives to help unhoused residents on a path towards housing, income, and health goals. And it's all provided through one of these little business cards here that is handed out to unhoused residents by a care provider.
Super. All right. Thank you, everybody. So we've got about 36.5 minutes to have a conversation about cost savings. And I'm going to start with the question. Almost all of you mentioned value-based health. I think that's become a term that means nothing. So I will stipulate that's my belief. I believe that because, less than about 10% of all care in the United States is delivered under a capitated or full risk model. And most of the shared risk models are just glorified fee-for-service models in a different kind of way. I think that about bundles, for instance, just, fixed price for a bundle, but then there's all the other bundles you add on to make up for it. So I'd love you to argue with me about why I'm wrong and tell me why there's really a value-based system that can accept what you're doing and why the current, probably mostly or definitely mostly fee-for-service system allows you to succeed.
Well, I'll comment on that.
I'm sorry, Michael, I'll let you comment on that. Use the little raise hand function. Okay. If you want to be the next, you got it. You're first, and then Tatiana, and then we'll go from there.
Okay. Well, I think when people talk about value-based care, they're talking about a lot of the things that you mentioned. What we're doing is we are actually going outside the system. As a physician, I realized that I was turning away people who wanted to pay cash. Basically, this is a large group of patients, if you include self-funded employers. In that, about 100 million Americans are insured via self-funded employers, and they're looking for a better solution than the current fee-for-service model. So the problem is people can't shop for healthcare because no doctors retail their services. So at the end of the day, what we're really doing is we're bundling, but we're putting something in a bundle that's functional, not multiple disparate CPT codes or ICD codes. If you hurt your knee, you want your knee taken care of. In the words of Clayton Christensen, patient has a job to do. What do? They show up. We might spend 5 or 50 minutes with them. We might do an X-ray, we might not. It's the same price whether you do, no matter what you do. The patient knows what they're getting in advance. And so we're really kind of going outside the system. So my argument would be, if you define value as, quality, cost, access, those kind of things, I think a lot of the companies here are maybe hitting that mark as opposed to trying to work through the legacy system.
Okay, thank you. Tatiana?
Absolutely, Lisa. So a couple quick things. There's this phrase by Ben Franklin that says, nothing in life is certain except death and taxes, right? But we talk about taxes every year. We're required to because the government tells us so, right? Mm-hmm. So for us, I think in advanced care planning and end-of-life care, the infrastructure to promote alignment also starts at the top. So CMS sees this as a huge problem that is one of the most costly things they've ever experienced. And so they've been pushing programs to help align those incentives, right? New CPT codes for advanced care planning, making it a HEDIS metric. As you mentioned, BIPC programs, but things like primary care first. And yet, kind of to your point, advanced care planning rates are still in the single digits. So it's not actually moving the bar there. And, you know, I think it ties into something a little bit more complicated, right? Where you have all of these massive incentive structures that are trying to either go fully at risk or transition systems from fee-for-service to an at-risk model or value-based model. But they're often hitting this massive bulwark of provider reluctance and the incentives that health systems and payers already have within their organization. And so, I mean, for us, the biggest barrier in terms of behavior change and in terms of driving people to actually, you know, capitalize on these incentive programs and these value-based care programs is driving behavior change in providers and systems. So that's my point there.
Vera?
Yeah, so you're absolutely right, Lisa, that today most of the payment models are actually fee-for-service models, maybe cloaked in different ways. So 100% true. So I think for companies like ours and you know everybody on the panel here, the trick is to identify ways in which you can actually create value within the fee-for-service ecosystem while looking ahead and also being able to get to that true value-based model, right? And I think, so if you look at what Constant Therapy is doing, what we're doing, we are delivering, we have a two-sided model. We have a platform that is allowing patients to be able to get AI-driven asynchronous, meaning you don't need a clinician available to work with you and get therapy at home after an event like a stroke or a brain injury. And in those cases, there just aren't enough clinicians to deliver that type of care. So if you look at a Kaiser or any of these types of health systems, for them, they just cannot provide adequate length of care for these patients and high frequency care that these patients need because it's a chronic problem. So for them, it does make sense to pay for something like a Constant Therapy to really extend that care beyond the walls of their clinic. So, but if you look at the other side, we also are providing solutions for the providers to be able to make that care delivery much more efficient. So the amount of time they can free up, which is reimbursable time, and to be able to practice at the top of their skill set is really important to them to be able to be very efficient. So we enable them to be able to monitor through analytics and data the care that the patient is getting. Also, to be able to provide evidence-based therapy while they are with the patient in the clinic. By doing that, we are providing a value to them as providers. So we have contracts with some of the largest rehab hospital networks in the country. And the reason for that is because it's much more efficient for them to deliver care through our platform than not. So I think we have to really create value within the confines of what is possible today and look ahead.
Value is in the eye of the beholder is your point, I think.
Yeah, and you know, the true value-based care models that we all are hoping for, it just takes a long time. And we've seen that movie play out over the last several years, and it's going to take a long time as we look ahead. We just have to recognize that.
Shirley?
Yeah, I think Telehealth is one of those companies on this panel now that is not based on a value-based care model. It's not our business model, but I do want to kind of give from our perspective what we've seen out there. And I think, you know, Tatiana, you mentioned something about provider reluctance. And I think it's not necessarily because they don't want to. I think it's very hard. I think that when we are meeting providers in the field or in the wild, as you say, and especially now this year, they are super stressed about, providing care and keeping their doors open and be financially whole. And any adoption of new value-based care models is also posing a risk for them. And adopting solutions like ours also has to come with a very, big question. do I have the capacity and budget to invest in something that, down the line will provide an ROI for me as a provider? I think that one of the approaches that we've taken is first, by the way, think about the patient before aligning incentives of others. Is the intervention something that is impacting patients first and foremost and really making their health care more affordable? And second, talk about business models that really align incentives between the other constituents in the ecosystem. And I think when we are working with providers, it is super important to make sure that the value we provide is directly impacting bottom line, and either it's better if it's revenue driven, and second to that is reduction of cost. And only then you can start developing a story that is great, and we are trying to do that. And it's super important to tie in clinical outcomes and downstream cost reduction into a broader value-based care approach. But I think that just meeting providers where they are at the moment, they are, for the most part, and maybe not the Kaisers of the world, very stressed about their financials and operating in negative margins a lot of times.
Yeah, Kaiser too. Todd?
Yeah, look, I echo many of the comments that were already made, and just would emphasize that healthcare is a business, and we don't often talk about it through that lens, where the primary business economic holder is the payer or the self-funded employer. And so, just like any business, they're looking for top line growth, margin stabilization, margin expansion. So if you just focus on that margin expansion effort, that's where a lot of value-based care discussions have gone. And I agree with you, Lisa. It's sort of a taboo word for us. We talk about provider incentives, because really the ways in which people have looked to employ programs, payers that is, or self-funded employers have looked to employ programs, is to say, how do we shift the risk to provider groups in a way in which we can stabilize or predict what our expense base is going to be? But has been called out many times during individuals in this panel, that risk can only be bared by certain types of provider groups who can have the balance sheet to be able to handle the fluctuations, because healthcare is a situation where biology can intervene in unpredictable ways and costs can get out of control. So we've been very much looking at Clarify to tailor programs that are more designed to one-sided incentives, where there's opportunities to both create margin for the payer, but also incentives for the provider groups, so that you're not having to bear the downside risk as a provider. Examples of this would be high dollar referrals for PCPs, site of service selection for surgical events. The easiest one is moving a joint replacement out of a hospital into an ASC. Same thing happens for GI and other types of surgical procedures. There's a lot of low-hanging fruit left that can be done in those ways to truly deliver better outcomes while also delivering the margin, which ultimately is what's driving the decisions that then get made available, or decisions about the programs that then get made available to providers in order for them to be able to earn the economic incentives or deliver the better outcomes for doing so.
Well, thank you, Mark.
Yeah, so your original comment was that we haven't achieved value-based care, which of course we haven't. I kind of look at it like the old saying, how to eat an elephant. If we focus on the elephant trying to eat it all at once, we're never going to get there, because healthcare is fairly complex, and you have a bunch of ingrained stakeholders who really probably don't always necessarily want it to change because they figured it out already, right? And so I think where we are today and looking at what tools we can leverage to help bring the stakeholders along with us is looking at different episodes, using bundles where we can or have to, but making sure that they're designed appropriately and not just another paper construct between a payer and a provider that's, instead of arguing over each line of every fee, just arguing about a bunch of them all at once. But if we take a bite at a time of that elephant, ultimately we'll get there, which I think your vision is right. In that it's everybody has this happy, healthy relationship with their provider, is attributed to a total cost of care network, has the services that they want. But that's a pretty big elephant. We're going to have to take some bites.
Yeah, although I've been working on this elephant for like 33 years and, we haven't even got the trunk covered yet. So Rob, how about you?
Okay, listen, I agree with everybody what they're saying. The big elephant in the room is CMS. Every insurance company follows what CMS does. CMS itself has not given clear indications what they want done. The only clear mandate they have created is that by 2030, they want 90% of patients in Medicare Advantage plans. So they can shift the risks downstream to Medicare Advantage, which may be Humana, Cigna's, you name it. The true value-based care has just filtered down to nephrology groups. Kidney patients are about 2% of total Medicare, but they take 20% of budget. So this has been a momentous shift in how Medicare has gone about in creating a complete risk bundle for all ESRD, which is dialysis patients and advanced chronic kidney disease for patients. They have held responsible large dialysis providers like DaVita's and Fresenius's to create these bundles of total cost of care where they are responsible to provide extensive care to these patients within a certain budget. Now, you're talking about the sickest of the sickest patients you're talking about here. You're talking about advanced diabetics with missing limbs, vascular disease patients, heart patients with bypass surgeries, TAVRs, not to mention hypertensive strokes, who spend a lot of time in nursing homes, rehabs, and mainly hospitals, right? Now you bundle those patients, you pass on the risk to LDOs, then LDOs go downstream to providers and say, let's join together and see how we can change and optimize the care so we can have shared savings. In this particular model, provider may get paid for fee for service, but is dramatically reduced and is then paid at the end of the cycle, where then they go into a shared savings bundle with a large dialysis provider. I think this will be a CMS a pilot for next 5 years before they roll it down cardiology and every other group. You know, Medicare and CMS has tried for many years to bundle risks, right? Even in the hospital, they pay based on your condition you're admitted for, pneumonia, congestive heart failure. This is why length of stays came out. Why does congestive heart failure has to be in the hospital for 2.3 days? Well, that's what the hospital is going to get paid. You stay more than extra half a day, hospital administrators get a fit, right? Yep. They come running down the hallways, get this patient out, right? So that's a risk hospitals have taken on. In that particular risk model, the providers are not necessarily held responsible unless they work for an institution like a Medicare Advantage plan, Kaiser's, or they work for some other institutions. So I think that the shift is happening, but unless CMS mandates this thing, how they go about do this, you know, it's not going to change. At Maya MD, we are bridging that gap between how we're going to go about enabling value-based care in this high-risk patients. Our patient population, in which we manage now close to 200,000 advanced chronic kidney disease, including dialysis patients, advanced heart failure patients, is to catch these patients from acute crisis, preventing them going to emergency rooms, which every ER visit costs about $12,500. The budget for Medicare patient for ESRD is $80,000 a year. So it's your super utilizers, your high-risk acuity patients, that's going to kill your budget. If you can manage those, you're going to see a dramatic, shift downwards in total cost of care. You can save dollars. I think once that's factored in, you'll see a better shift.
Thank you. Rich?
Yep.
Sure. So I was going to talk a little bit on the prescription medicine side of things, because I know we've been talking mostly about medical value-based care. And I think what we see with pharma and payers trying to come to agreement on value-based contracts is there are some challenges with reaching agreements because of how outcomes will be measured and how real-world factors may prevent the therapy from having the hoped for impact. And so what we've seen, for example, is that some manufacturers are looking at using Somprey to improve adherence in the real world up to the levels that they saw in the clinical trials, so that they then feel there's more chance of being more fairly measured for outcomes, and therefore a value-based contract becomes more palatable. But I think solving for those challenges of measuring outcomes and agreeing that you're going to get trial-like situations that therefore make it reasonable for the pharma company are some of the impediments on the prescription side.
Boy, that's a tough one, measuring compliance as the outcome, because the outcome should be outcome, right? It should be clinical outcome. Just because you take more of the drug, if you're still sick, what good is it? It's a real interesting problem, I think, in pharma. Tatiana, are you looking to speak again?
Absolutely. So I wanted to touch on Mark and Schulich's point. I thought was very interesting. So they are right in that, it takes time to recognize value, but you still need to keep the doors open, right? So I think some of these new programs that almost have a carrot and carrot approach rather than a carrot and a stick, carrot now and carrot later, are helping to bridge some of that gap, right? So the performance metrics that allow systems to cash in on bonuses sooner as they wait for those savings to accrue and to be realized, right? But I think to Gaurav's point, it has the highest impact on the super utilizers within healthcare. In Medicare, that tends to be the oldest and the poorest, right? The lowest socioeconomic statuses tend to spend far more on healthcare than the upper third. But what that also means is increasing access for those individuals. So standard of care rarely actually serves these these folks. For example, in advanced care planning, traditionally that's done through an estate planning attorney or through direct-to-consumer solutions, right? Very rarely is it brought into a clinical setting. And even then, to I think Shrulik's point, most providers, they don't really have the time, tools, or training to engage in a high quality conversation. And so really they just relegate that to folks that have just been diagnosed with a serious illness or who have reached a critical inflection point. And that is often too late. Patients have lost capacity, et cetera, et cetera, et cetera. What then happens is by shunting all of this work onto providers and relying on the standard of care and saying, hey, patient, I want you to do this on your own if this is something you care about, we're cutting entire swaths out of that population that actually drive the value in value-based care, right? So at CODA, much like Samaritan, which is actually a good friend of mine, we've pushed CODA and advanced care planning into the lowest socioeconomic status communities, to communities that are unhoused or housing insecure, to individuals that have been minoritized, right? And that is where we see the greatest impact, not on sort of the wealthier populations that are already going into clinics, that are really in charge of their healthcare, that are, medically literate.
Thank you. Ashish?
Yeah, thanks, Tatiana, for that segue. Just to kind of use her as a jumping off point, we're focused on the highest cost, highest utilizing, highest risk patients who, as Tatiana mentioned, are going to be the poorest and sometimes even older patients. But even with that, Lisa, I think you hit it right on the head with value is still in the eye of the beholder. And we really need to thread the needle between planning for value-based care, but also existing within the confines of this fee-for-service model. And unfortunately, as long as homelessness will exist, as long as we do not have the political or the human will to take action on a catchy phrase, housing is healthcare. And just knowing that people who don't have a home are 30 times more likely to land in the ER, it is more than just about cost savings. And while the direct support that our platform delivers does result in upstream cost savings through reduced ED utilization or reduced length of stay in the ED, health plans and providers are largely already invested into solutions that are helping these people, like tiny home villages or referral systems and jail diversion programs. So, at Samaritan, we like to think that we're not really here to replace a lot of these existing solutions that are necessary and are already doing some of the work. We're here to just improve the outcomes and the ROI that health plans and providers are getting from these solutions by providing that direct financial and social support that people need to actually even engage with these resources. So I think that reduced ED utilization and driving engagement from a hard to reach population is a plus, but it really starts with building trust with the community of people who have difficulty accessing services or even trusting services, and amplifying the work that providers are already doing to ensure people can stay within a network of care.
You sound like your people actually care about people, and I'm not sure the health system is designed around that particular incentive. Gaurav, would you like to comment?
Yeah, just to Tatiana's point, and she is spot on, right? A lot of these patients who actually end up in a hospital
are diagnosed with a terminal disease or given a chronic disease diagnosis, which may lead to a, let's say dialysis or a terminal disease, one of the things with the value-based care, at least at full risk organizations, is our platform empowers determining the social determinants, right? Our platform actually engages patients to determine their social, so we are aware, their access to food, their access to medications, prescriptions. We even inquire about their appointments and the rides. If we don't have a ride, our platform informs the practice, because under value-based care, you can actually pay for their rides. You cannot do that outside of value-based care, because then it will be called, you can actually are enticing the patient to come to your office, which again, you can put you in a Medicare jail. So one of the things we also do, Tatiana, is we actually connect patients and their families to attorneys who actually will help them make those decisions about make a will. What do you want done? End of life discussions. Would you want dialysis or not? Right? Here's education on dialysis. I wanted to make that point.
Yeah, I first of all, I 100% agree with what you're saying, that that's possible and probably also a good thing to do, a very good thing to do. Our political system doesn't really like that. Some of our patient advocacy systems do and do not like that, depending. And if you think back to like when I started in the business, which I may be older than all of you, I don't know, but in California, at least where I was and am, there almost 100% of the population that was commercially insured anyway was under value-based, full capitation, HMOs, old-fashioned kind. And that was unwound to a large degree for political reasons and from political pressure from the provider community, the patient community, et cetera, because it was perceived as a way to facilitate, letting people die or taking care away from them because that saved money, which, factually kind of does, but it's, not what we'd all hope for ourselves and our family. So, how do we solve that problem? If we're pushing towards this mode of full capitation, because you can do all that you wish, to take care of a patient the right way, in theory, how do you solve the problem of how that's perceived by others who don't believe that's the right way? Tatiana?
Absolutely. This is actually my favorite problem to talk about. So I think there's obviously a lot of complexity here, right? Yep. But 80% of patients actually want to talk about proactive healthcare planning, end-of-life care planning. Oftentimes it's, from our experience, it actually boils down to providers and family members sort of being reluctant to that conversation, right? But taking a step back, one thing that I will say is, we provide a service for people to capture their decisions, right? Whether that is, hey, I want all of the care in all of these contexts. This is what quality of life means to me. These are the things that I value. And it gives the medical decision makers the instruction manual and the permission slip to act on those preferences. And for those populations who've historically received less care than they've asked for, to advocate with an actual document and a well-informed plan for the preferences that they have selected, those informed preferences. Similarly, people who don't necessarily want aggressive medical intervention can also do that, right? To Samaritan's point, communities that are housing insecure or unhoused, the standard of care is your medical power of attorney or your medical decision maker is de facto your spouse or a family member. Yeah. For those communities, they haven't spoken to those people in decades, right? How are they going to know what kind of preferences you have? And so they're vastly underserved. Yeah. And so one way that we've approached this issue is through a perspective of advocacy, right? So we empower patients to advocate for themselves, regardless of their preferences. And we also know that patients that have advanced care plans are more likely to engage in hospice and palliative care. They have higher remission rates because they have access to palliative care. And they have higher satisfaction with their care, as do their families. So again, really complicated issue, but we can do it.
Michael?
Yeah, thank you. Sorry, I was muted. I think at the end of the day, a lot of the things we're talking about today talk about incentives. How do you align incentives? You mentioned the old school kind of managed care. The incentives weren't aligned for the patient there, right? Or the providers to some degree. They were heavily weighted for the payer. I think to align incentives, we really need to start from scratch almost. I mean, trying to layer on solutions to our existing, system, which is broken. I think we can all agree that, and trying to come up with incremental improvements is great. But, what we're doing at the end of the day is we're trying to align the incentives for everybody, right? If a provider can offer, a service that's bundled for a price they feel is reasonable, they set their own price in our model. The patient or payer can then look at quality, they can look at price, and then they can make a decision on which provider to see and which services to purchase, right? And I think at the end of the day, the doctors win because they're setting a price that's reasonable, not their sticker price or charge master price. The patient wins because they can access care for a reasonable price, stay out of the emergency room, stay out of the hospital, get better value of care at, maybe an outpatient location. And the payer wins because everyone's aligned there. The payer saves money, the patient gets the care they want, the provider gets business and can actually take care of the patient without having to jump through a bunch of hoops and spend, 15 cents on every dollar to get paid. So at the end of the day, I think we can align incentives. We can solve a lot of these problems, and really that's what we've set out to do with our platform.
Well, that sounds easier than it is, I think. Vera?
Yeah, I think at the core of it, I think the if we start with patient engagement and provider engagement, I think we can really align all the incentives. So if you think about, and by the way, I mean, I agree with you, Lisa, the world when the HMOs were dominant, very different world, but we're in a different world today. If you look at what patients want right now, they do want much higher engagement and access to care. So if you think about constant therapy, for example, we are seeing significantly, patients raising their hand and saying, hey, you know what, we want to use this at home. And it's not really replacing the clinician, it's augmenting what they're doing. So the incentives are aligned because the patients truly are being engaged. And these are, by the way, very difficult to engage patients like stroke patients, maybe they can't speak or read or write, and we're able to engage those kinds of patients. I think if we do that, we can align incentives. And the other thing I'd bring up is now, if you think about some of the biggest problems we are trying to solve, there just isn't enough providers available, clinicians available to provide a lot of the kinds of care that is needed by patients. And that's been exacerbated significantly with the provider shortages that we all know about that's happening right now, and burnout. So we live in a different world where clinicians, patients, as well as payers need to actively, we have to solve this problem. I think everybody recognizes that, and there are tools now available that are truly engaging to make this happen.
Thank you. Sean.
There we go. Thank you. I appreciate that. Our focus is a little different. We're more of a product company and more focused on the patient side. But what I see is that provider success is often based on patient compliance, right? So if we're going to go complete our therapy care plan and make sure we don't get readmitted, we're going to do the proper steps through other providers, right, to meet that care plan. So patient motivation is critical. And that's actually one of the things that I see where technology makes a difference, and our technology in particular, is gamification, right? Being able to incentivize people to do therapies and do boring things, but do it in a way that's gamified. And in VR, we do that. We keep track of scores. We have ways to make people be able to see their progress and report that back to their clinicians. So I think, and it's also talking back to the other point, it's available for home use, right? And it's a massive increase in patient engagement. So that's the other side of this challenge that I haven't really heard anybody hit on yet. Everybody talks about the providers and the tools and that side of it. Well, patient success is key in there too, right? And keeping that patient engagement, keeping that patient motivated, but more importantly, giving them an actual modern tool that they can use to recover with. That's one of the big things that I'll give a quick example, and I'll be done, I promise.
We don't have time for examples. I'm so sorry. We have 2 minutes left here.
Simple. So I had a stroke 2 years ago. This was my therapy recovery tool, an X on a piece of paper, right? That's the tool. Are you really motivated to sit and stare at an X on a piece of paper, or would you rather sit down in a VR?
Only if you're a tic-tac-toe champion, I suppose. Mark?
Yeah, so I think your question was, how do you deal with the detractors, right?
Yeah, we have very short time, and I realize a big topic, so we have like 30 seconds.
Well, that's a simple answer: is you improve outcomes. Because if we can improve outcomes, then the providers aren't going to complain, the payers aren't going to complain, and certainly the patients aren't going to complain. And where we are at Wildflower Health, we focus more on the beginning of life, whereas a lot of the talk here is a little bit more on the Medicare side. Patients want to participate in their care, but it's really hard, and we don't make it any easier in this country. Providers want to provide the best care they can, but we can't get them the whole patient information, which we talked about. And so that's where I think we can use that combination of technology and support services to improve the outcomes, which ultimately is everyone's goal. And when we get there, I mean, how are you going to politically argue against that, essentially, right?
They'll find a way.
30
seconds to Todd here.
Wow. Okay. Well, so I'll say this as quickly as possible. So just picking up on what you said, Gaurav, about the industry goes as CMS goes. What the word on the street is that they're going to implement subcapitation of high dollar specialties. And so we've seen some independent practices doing this commercially, particularly in orthopedics. And to your point, Lisa, about sort of where do the detractors come in? One of the large practices we work with last year had their first year where they were so proud that they got paid more for not operating than operating, but that asymptotes to a place where now people are not getting appropriate care. So that's where I would put our emphasis, which is the assessment of appropriateness is the key, and incentivizing when clinicians offer appropriate care in the best consent and informed consent of the patient. But we've been technologically limited from doing that, but we're very close. And that's what I'd say where we're investing a lot of effort is being able to assess our risk-adjusted, case mix-adjusted appropriateness decision such that we can incentivize when the right care decision is made, and it's a win-win for everybody, or a win-win-win, frankly, because it's lower costs, better outcomes, and the providers can be appropriately incentivized for the decisions they're making.
So I'm sorry we don't have more time because I know everybody has a lot to say on this. Is a big topic. You could talk about this for months, years, probably. And I do appreciate very much all your participation and all the lively discussion. I think this is the great challenge of healthcare, really. I mean, we could provide good care to people. We could provide all kinds of services to people. We can provide access to care. We can provide advanced care planning. We can provide great, maternity and childbirth care, all of these things if we have the will. And unfortunately, our financial model of healthcare in the country really limits us in many ways because everybody's incented to either keep it as it is or make it worse or fix it to their favor. And it's a really challenging thing. One thing I'll caution all of you in the startup world is that shared savings is not a panacea, because once you've created a savings baseline by year 2 or 3, now there's no more savings to share. If you're doing a good job, and it becomes very, very challenging then. And so having been through that more than once, I can assure you that is not the answer in the end. Nevertheless, hopefully we will all win and go and force the system to the right direction. I thank you so much for your time today and look forward to seeing you in Vegas in a few weeks.